Welcome, everyone, and thanks for being with us today. I'm here with Dr. Karen Harpster. Dr. Harpster is the Director of Research for Occupational Therapy at Cincinnati Children's Hospital in Cincinnati, Ohio. So thanks, Karen, for being with us. Could you just tell us a little bit about yourself and how you came to be in the position that you're in?
Sure. Thanks for having me. I am an occupational therapist who practiced for quite a few years before I figured out what I wanted to do in life. And then when I realized what an occupational therapist was, I decided that not only did I want to get my degree in OT, but I wanted to do research in to learn a little bit more about. Originally, it was sensory processing in kids with autism, but then when I came to Cincinnati Children's, my research changed to look at children with cerebral palsy and children with cerebral visual impairment.
Gotcha. And so, how long now have you been the Director of Research for Occupational Therapy at Cincinnati Children's?
I have been here for 11 years and I've been doing the same thing since I've been here. When I joined the group here, I was the first PhD trained occupational therapist. So I kind of started the OT research here at Children's.
Nice. So, what is your when you say started research? What kind of things are you doing with the other occupational therapists and that are at Cincinnati Children's?
So I sit on a research team of now two OT PhD trained people. So we will guide the clinicians in research projects that they come up with based on their clinical practice. I also do a lot of independent research, like I said, in it both with babies who are at high risk for CVI or CP. So a lot of early detection work and a lot of early intervention work for both of those populations. So some independent projects, and then I guide other OTs who want to do research in the line of practice that they do. For example, one of our NICU team just got a grant, and I'm the mentor on that grant to look at the transition from the NICU to home.
Nice. And then, so are there a lot of research directors at children's hospitals around the country?
There's a handful that I know of, but I don't think it's a very common role. I don't know the exact number, but I know at least, less than 10. And sometimes when we go to different conferences, we'll meet up and have dinner and kind of talk about different research projects that are happening.
Nice. And so you said you were kind of interested initially in sensory processing, but then became interested in CVI. Could you talk a little bit about how that came to be?
Yeah, so it was one of those projects that I was almost assigned to when I got here. So I didn't really know much about it. We brought a researcher or an educator in from another institution. Her name is Dr. Christine Roman Lancy, who does a ton of research in CVI. She wrote the CVI range, which is one of the tools that we use, and she kind of taught me a lot about CVI. And then once I had that initial training, I was just intrigued, and it kind of spiraled from there. We have a group of a couple ophthalmologists and optometrists at the hospital that are very interested in CVI. So we have a group that we work very closely on both clinical and research projects. And so that's kind of how it started, in in-service here at the institution, because what we found is that kids who have CVI are very underdiagnosed, and they can often get missed in the process. And so we wanted to develop a program where we could provide comprehensive interventions and or evaluations and assessments for children with CVI.
And that's really why I wanted to have you on, is to help occupational therapists and occupational therapy assistants kind of learn more about CVI and figure out how it might be helpful for them in their own practice. So could you start by telling us what is CVI?
So CVI is a neurological vision impairment that occurs when a child has some kind of damage to the visual processing centers of the brain. So when we think about vision, there's the anterior visual pathways, so that's like how the eyes are seeing, and there's the posterior visual pathways that show us how the picture or what the eyes are seeing, how it's getting processed. So when you look at a picture, the picture is formed in the eyes, and then it's converted to like electrical signals that are passed to the optic nerves, and then it goes to a processing station, and then to the back part of the brain, which is where the processing happens. So for children with CVI, they have difficulty with processing what it is that they're seeing.
Gotcha. So how do you differentiate CVI from other types of visual impairments?
Um, Sometimes it's hard.
Hmm.
Sometimes it takes a little bit to sort out. But what, as an OT, what we look at is how what's the functional limitation of the visual impairment. And so the way that CVI gets diagnosed is that there has to be some kind of insult. 90% of the time there's an insult, some kind of insult to the brain, and that can be anything from like oxygen deprivation. They could have had a stroke, they could have hydrocephalus or some kind of trauma. So unfortunately we see some babies who are shaken babies. Infantile spasms is a big one that we see, or maybe they were exposed to drugs while they were in the womb. So there's usually some kind of insult to the brain, and then the eye exam doesn't match their vision. So, for example, some kids with CVI might have 20/20 vision, but they're still having difficulty with their ADLs. And so, as the OT, it's our job to do a task analysis to figure out what's vision and what's motor and what those different aspects to kind of sort it out to see um, where the impairment is, or what's the biggest impairment that's getting into the way of the child's functional performance.
Gotcha. So that's interesting, that the differentiation between maybe acuity or what the eye exam is saying, and then what performance is happening. So you're an OT and you've got maybe some suspicions. How do you go to get CVI diagnosed? Is that kind of a typical going to lens crafters sort of situation? If Lens Crafters is a sponsor of this show, no offense, I actually got my glasses at Lens Crafters, and they do a heck of a job. But how do you get that diagnosed?
So you would have to go to a team who specializes in neurological visual impairment. Um, a lot of I mean, CVI is a somewhat new diagnosis. I would say it's not really new, but I think awareness of CVI is newer. And so I can talk about how we do it here at Children's. We have a CVI clinic. So kids will come to us by either one of two ways. If there's suspicion that they potentially have CVI, they'll come to our clinic and they'll see a multidisciplinary team. So in our team, we have an ophthalmologist or an optometrist.
What's the difference between an ophthalmologist and an optometrist?
I mean, really, they're schooling, and so there's the ophthalmologist goes through more schooling. They can both diagnose CVI. Ophthalmologists might do more surgeries and those kinds of things, but it's more of their preparedness in their schooling. So we have both of them. We have we have two teams and one on each. And then they usually see an OT and then a teacher of students with visual impairment, or you might hear them called TVI. Sometimes there's an orientation and mobility specialist. We had one here, but then she went to she went to the schools. So we're looking to bring another one on into our CVI clinic. So there's that team of professionals. We see the kids for 2 hours, and we see them together for the first hour. So that's where they'll get like their visual acuity exam. We do contrast sensitivity, color testing. They'll do the ophthalmologist will do a lot of those things, field test. And then the occupational therapist will do more of the functional vision piece of that. And then the teacher of students with visual impairment, or TVI, will do a reading assessment if they're of the age where they're reading, and give recommendations for their school or things that might happen in school, as like on their IEP. The other way we'll get kids, if they don't come through clinic, they might have seen an eye doctor in the eye clinic, and if there's suspicion for CVI, then if they've already seen the eye doctor, then they'll refer them to OT, where we'll do our functional vision eval. That can we do with our functional vision eval. We do both parent interview, we do direct observation, and then we do some formalized assessments depending on the child's age and or their abilities. So we'll kind of do that.
What kind of functional performance are you looking at when you're as part of that evaluation?
So when we do the functional vision evaluation, we look at, a lot of different things: visual attention, their visual motor tasks, their ability to reach for things, their facial recognition. There's different apps that we use to see, if a child can recognize familiar faces. So it's called 9 Gaze. So we take pictures of the people in the room, and we will see if the child can find their mom or find themselves or find, the ophthalmologist in the room, to see how they do with facial recognition. We will also look at things, pay attention to when we get them from the waiting room. Are they looking around? So what does their visual curiosity look like? Are they if when they walk into the room, do they play with toys right away, or are they avoidant of new things? Then we also will change the environment up. We do a lot of environmental and task adaptation. So we might do the same activity with both the lights on and the lights off, to see if the environmental modifications make a difference to the child's visual behaviors. We talk a lot about visual behaviors. Um, so, for example, to put that into context, like I might have the child reach for a toy. We might do that with the lights on and then the lights off. We might do that with a toy that's lit up and then a toy that's very complex, to see when they reach for a toy, how does the environment and how does the task change their behaviors. Do they look away when they reach? Are they looking at the toy when they reach? Are they not interested or not even reaching at all? So there's a lot of different things that we do with the kids, clinical observations, that will help us figure out what we call there's a lot of visual behaviors that you see in kids with CVI. If they look at it, if we can get their visual attention, we'll look at how long will they fixate on an object. If they, depending on their age and their abilities, can they visually discriminate? So if I hold up two different pictures, can they find, the lion versus the tiger? Or if if I hold up a 3D object, can they discriminate that thing? So there's a lot of different things that we can do that will help inform the intervention and how to set up the environment during intervention or school-based activities.
And then are there any standardized assessments you use as part of that as well, or?
Yes. So again, it all depends on the child's level of severity, their age, and their abilities. But I mentioned the CVI range already. That's an easy assessment that we can do with kids who have CVI. We can start that assessment at 9 months, and that's it's a subjective assessment. It's not standardized, which is a little bit tricky sometimes. Here at Children's, we developed a way to standardize it amongst our clinicians, so to make sure that we're all doing it the same way. So we'll do the CVI range, and then if the child can, for 3 to 6 year olds developmental age, there's a test called the CVIT assessment, and so it's it's just visual. So when you do that, it's computer based. The kids will look at different pictures, and you'll ask them, are they seeing, different, like Dora the Explorer is in one of the pictures. And the way that the test changes is they'll show you Dora without background information, and they'll show you Dora with background information, because when you add complexity to things for children with CVI, it's often harder when there's a complex background versus a not complex background. It looks at movement discrimination. There's 14 different subtests, so it gives us a good idea of a lot of different visual skills of kids with CVI. We also do the Berry VMI, so there's 3 subsections to that. So we'll look at their visual perceptual skills and their visual motor and visual motor coordination skills. Really all dependent on the child's ability. We'll kind of tailor the intervention or the assessment to the child's ability level.
Gotcha. So everyone's done their bit of, and this all happens in 2 hours?
Yes. Sometimes we have to bring them back to, so the way that it happens, we see them together for about 45 minutes to an hour, and then the OT will pull them out and see them by themselves to finish up. And so, yeah, we can usually get it done because most kids will only do 1 or 2 tests, depending. The higher functioning kids or the more mild CVI, we will do, we'll jump right to the higher skill test, and we won't do some of the other things I mentioned. So we try to go to like the highest test that they would be able to do.
Gotcha. So everyone's done their bit of this kind of evaluation in the round, and then what happens? The team gets together among yourselves.
Exactly. So we meet with the family. So we will bring the ophthalmologist or optometrist back into the room with the parents, and we'll kind of describe what we saw and what we, whether or not a diagnosis is warranted. So the ophthalmologist or the optometrist will either diagnose them with CVI at that point or not. Sometimes there's kids where we think it's suspect, so they'll kind of tell the parents, or especially for babies who are younger, we might say that they're at risk for CVI, but there's not enough at this point to be able to tell. Sometimes when they're in that transition age where we can't quite do some of the 3-year-old tests, we might kind of say, come back in a year and we'll do some more tests. But these are the things you should consider, and these are the adaptations that will help your child, regardless of whether they got the diagnosis or not. So we'll talk with the family, and then recommend treatment, of course, if treatment is warranted. A lot of times the kids that come to clinic are coming from different states. So we might recommend we touch base with their therapists that are closer to home, and we will kind of guide them. The one thing we just added on more recently was that the OT will do a telehealth session with all the parents after the clinic visits to or to teach them about CVI. So, what you can teach them in the end of a visit is not very much. And we wanted to make sure that the parents feel confident because the environmental and task adaptations that we recommend for these kids are so important, and they're going to change the way a child's going to interact with their world. And so we want to make sure that the parents understand how to set up the environment to be able to promote motor skills or promote language skills. So we set up telehealth education sessions with them, and we create an individualized PowerPoint where we go over all the CVI strategies. We teach them about how to understand whether or not they set up the task or the environment at the appropriate level. So how to read their child's visual behaviors. We teach them about the just right challenge and what behaviors might mean. For example, if a child's looking away a lot, we might tell them that that probably means either something is too complex, so let's reduce the complexity, or the child might be tired, let's give them a visual break and come back to the activity to see if that little change might change their visual behavior. So we teach them how to read the child's visual behaviors and how to understand whether or not you're set up at the right level for the child.
So how many states are you licensed in?
I used to be licensed in 3 or 4, but now I'm only licensed in 2. So we have certain therapists that are licensed in Indiana. I'm Kentucky and Ohio, and other persons West Virginia. So like the surrounding states. In other situations like that, I just saw a patient right before this that was in Virginia, so we'll just do a phone call. We can't do telehealth, but I still, we've done their training session in person, so they usually come for like a week at a time. And last time they were here, we just scheduled 2 visits, one where I did the evaluation and the second one where we went through the training. And it was nice to hear the feedback today. They said, oh, he's 2 years old, so he's in that transitional age to preschool, and they've been sharing the PowerPoint with his team, and have found has been very helpful to kind of educate, because a lot of people don't understand what CVI is or what to do for kids who have CVI. So it's a thing. Not only does it teach parents, but they can then share it with their care team so that they can understand about CVI a little bit better.
Well, so I mean, you're one of my former students, so I just want to say how proud I am of you. And um, at some point, the teacher or the student is smarter than the teacher, and that probably happened back at Ohio State back in the day. But just kind of your knowledge on the subject is just amazing. And you've been there now 11 years. So at what point do you feel like you started to get comfortable around evaluating kids with CVI?
So we kind of kid around about that here. When I first started, and there was 3 of us that went to the original training, and we had no clue what we were doing, because you show these kids things, and you have to kind of figure out, are they looking at it? Do they see it? Do they know what they're looking at? And I think it took me probably a good year before, so now I'm the only one of that group that is still doing CVI. And when I see some of the other, like the other 2, they say, oh gosh, like, I can't believe you're still doing that. But I think, it's easy now. I can do it really well now, I think. But it took some time. It's really hard to understand those visual behaviors and what do they mean. And we get a lot of kids who have co-occurring diagnoses. And so when you have a child, we'll just say with quadriplegic CP, and they have a vision impairment, and they might have an ocular and posterior visual impairment. So it's really, you have to kind of really sort out a lot of different things and figure out, if with a child who's not going to reach for a toy, are they seeing it? Do they understand what they're seeing? So you develop strategies, and we have toolkits that we kind of put together on our own as we kind of learned a little bit more. So we have our CVI carts, and so we add to it every chance we see something new. But it's just fun.
Hmm. So, could you talk a little bit about this? Is an obvious question, I guess, but why is vision so important to occupational performance?
Yeah. So, I mean, I think especially for kids who have CVI, like I mentioned, the co-occurring diagnosis, it gets overlooked a lot of the time. So people just assume that kids aren't reaching for a toy because they can't reach. But if they can't see what they're reaching for, they're not going to reach for it. So I think almost you have to think of vision first when you're trying to work with children who potentially could have a CVI. And so, we just did a focus group actually with an Ohio State, two OTD students, but one of them was from the Ohio State University. And we wanted to get parents' perspective. What was it like to raise a child who has CVI? And quite a few of them mentioned that until their therapist realized that vision was the key factor in holding the child back, they weren't getting anywhere. And so, like, a quote from one of the parents, one of my favorite quotes, was something like, this is not a direct quote. It wasn't until we put a mat on the floor to cover up our oriental rug to realize that if he can't see what the physical therapist wants him to crawl towards, he's not going to crawl towards it. So once they made some environmental adaptations and realized the importance of vision, when the motor skills started to develop. Or another little girl whose mom I just saw the other day, she says the same thing until when some kids, especially if they have infantile spasms, the parents are so worried about their survival. And so once they get those medical issues under control, and they could start to work on the visual skills, her motor skills just completely started to develop after that. But if you don't have that awareness of how much vision impacts, if you can't see it, you're not going to move towards it. If you can't see it, you're not going to reach it. If you can't see it, you're not going to roll towards it. So once you can figure out that vision is a primary factor in the impairment, then I think that the children are that much better off. And even for kids who have CVI, I mean, the modifications that we make are not rocket science. They're just easy things that we will adapt to help the child attend to whatever it is that we want them to see.
Gotcha. So, in terms of all of your vast experience with these evaluations, are there a couple of, I know every child is different, but are there any sort of telltale signs when you are working with a kid that might say, as a less experienced occupational therapist that's out there, that maybe I need to look at CVI a little more in depth?
Yeah, there are. I mean, I can answer the question about behaviors. There are a lot of them that are quite frequent. Some of them are, that they have difficulty with the lower visual field. So there might be a big basket on the floor, but they kind of walk right into it. Or they're, when they're going down steps, they might use their feet to feel where the step begins and where it ends because they can't see. If you think about a step, it all looks the same color. You can't really see where it begins and where it ends. So that's a common behavior of a child with CVI. Kids will look up at lights. It's easier to look up at the light than to process the busy, complex world around you. There are a lot of behaviors, and where I was going with this is there are a lot of screening tools that we can use as OTs and really any profession to be able to look at early signs of CVI. And so those screening tools are mainly based on behaviors of kids who have CVI. The one that we use for kids who are 0 to 2 is called the Previous, and it's 30 questions, and it asks for about different things like, does your child look at their hands? Do they do different things in the environment? And the parents just answer yes or no, and it's been validated and found reliable to be a screener for visual maturation. And so if you are an OT and you're working with a child who maybe had a stroke or maybe had some kind of brain injury, then it would be worth doing that questionnaire. It's freely available. It's easy to do, and it helps us understand some of the behaviors. There's other tools. The tools vary based on the child's age, but depending on the child's age, there's one specifically for kids with CP. There's one that we use often. It's called the Teach CVI, and that's divided into three tools based on Teach 1 would be for kids who are non-ambulatory, because the questions are obviously different if the child's not walking. Teach 2 is for kids who are a little bit younger, and Teach 3 is for kids 6 to 12. Again, they all just ask about all these different behaviors that are very common in kids who have CVI. The other questionnaire that we use often, the ophthalmologists use it during their visits, but one of the, I would call him a grandfather of CVI, his name is Gordon Dutton, and he has two different questionnaires that are easy to use, and the ophthalmologists here use it. One is the 5 questions, and they answer from never to always to things like, do they have difficulty walking downstairs? Do they have difficulty finding animals that move quickly? Can they find clothes in a pile of clothes? So there's 5 quick and dirty screening questionnaires that the ophthalmologist here will use. Then there's different versions of it. So that's the 5 questions. We more recently started to use his 11 questions to look at kids who are more higher level CVI, so a less severe CVI. Some of the questions are the same, but not all of them. So an example of the one that's not the same is, is your child distracted when they're doing something for a long period of time, or can they find their friends when they're standing in a group? So that visual discrimination those kinds of things. Do they trip at the edge of the pavement if they're going down? Can they see that? And again, just really quick and dirty, the behaviors that are common in kids with CVI can tell us whether or not a full comprehensive vision evaluation is warranted. Because if there's different ways to score them, and if they are positive, then that tells us that they should get a full vision evaluation.
Gotcha. And those of you that are listening to this on occupationaltherapy.com will have a list of some of those assessments. And you mentioned the Berry. Is there anything within the Berry that might kind of give some clues that you need to look at this a little more deeply? Or
I mean, that's a little bit trickier because the Berry, we can really only do the Berry on kids that are like mild CVI, so the higher functioning kids who have CVI. And so I think it's just a higher level visual perceptual deficit, which could be CVI or could not be. So they have to have some of those other things that I had mentioned, that it will help diagnose or not CVI. So because we use that in other populations, and kids who don't have CVI can have a visual perceptual deficit, it's a little bit trickier. I would do the Berry plus a parent questionnaire or the Berry plus a parent interview to understand some of the CVI behaviors that we would expect.
Well, and just the real advantage of being part of a clinic team where you've got other professionals there that you can sort of discuss those things in terms of the diagnoses.
Yeah, and it is a group discussion after we kind of do all the things. It's kind of, it really is. Obviously, the OT doesn't diagnose, but I feel like the input that the OT has helps the ophthalmologist and the optometrist come up to that conclusion.
And especially in year 11 as opposed to year 1.
Right.
I bet your input probably has a lot more weight to it than maybe back in the day.
Yeah.
So what you talked about some co-occurring diagnoses that happen with CVI. You mentioned cerebral palsy, stroke. Are there other ones that might be common that, at least for the occupational therapy practitioner, they might think about CVI if they have a child that they're working?
Yeah, I mean, probably the biggest co-occurring would be CP. There's a really high co-occurrence, but really, we see kids with autism and CVI. We see kids with developmental coordination disorder and CVI. Sometimes, if you see a kid with dyspraxia, that can be co-occurring. So there are quite a few overlapping conditions, and it's really, with my prior knowledge of children with autism and CVI now, it's probably one of the most fun for me to sort out. And you can't do it in the 2-hour evaluation, but we try the CVI strategies in treatment, and we try to be like little detectives to understand if we adapt the environment and if we adapt the task, does that help their visual behaviors? But it's really tricky to sort out sensory and vision because it's so overlapping. But even regardless of the rationale behind the behaviors, if the CVI strategies help, ADHD, that would be the other co-occurring condition that we see a lot of times. But with those co-occurring conditions, a lot of times the CVI strategies will help, and then it'll promote better attention and then better learning.
Would you say that these changes kind of come on suddenly, have always been there, are more gradual over time, or is it just kind of depend on the, maybe the co-occurring diagnosis that might be leading to it?
So I think that they're probably there all the time, but I think that kids are so resilient that kids, when they have a mild CVI, they overcome a lot of it, and it's not till their school age and they're having difficulty with things like reading or writing that where we might kind of think about that, or they'll get referred to the clinic and we find out that when they were younger, they did have a small stroke and they had this. So then we kind of consider those things. So I think the things have always been there. When the CVI is more severe, it's pretty obvious. So it's easier to see. But those mild kids, I think, are the kids that have had it the whole time, but they just are, they can adapt and they can figure it out. It's not until those higher level skills come out where we see it. One of the things I always tell parents, like one of the biggest principles that I tell parents is if the kids are doing something that they're familiar with, then we can challenge their vision. When and then when they're doing something that's novel or a new or hard task, then we need to adapt for the vision. And with those kids who have a mild CVI, that's where we see it come out. Like they do all these things that are easy and their vision isn't affected. It's not until we get to school and there's a lot of information on a page, worksheets are very busy. When they get to those really higher level skills, when they need those adaptations, we don't see some of those things until then.
In terms of treatment and some of the toolkit that you sort of talked about, what are some of your strategies that you would start using? And I guess you talked about the PowerPoint that you help the you send the parents home with. What are some of the intervention strategies you'd use?
So the adaptation strategies that we use are based on, again, the child's visual skills. So it's a little bit tricky of a question, but most of the time, every kid who has CVI will need an adaptation for complexity. And so when we talk about complexity, we talk about how complex is the environment, and we can make environmental adaptations, and how complex is a task. So if I'm working with a baby and I want them to reach for a toy, sometimes kids with CVI or babies with CVI will reach for things more if they're either lighted or they have a single color. And when you think about babies, all of baby toys, they're multiple colors, they all make noise, they all light up. Is a lot of sensory things that are happening. And for kids with CVI, babies with CVI, sometimes they need just one color or just one sensory thing to happen. And a lot of times that's a light up toy. Um, for kids with CVI, when it's hard to use your vision, a lot of times they're better at using their hearing. So when I'm testing CVI, I have to try to use toys that don't make noise, because if they look at something that's making noise, I don't know if they saw it or if they heard it. So that would be an adaptation. If I want a child to look at something, I would use something that has no noise. So reduce the auditory stimulation or reduce the number of colors that they're looking at. So that would be complexity. How complex is the object, and does that need to be less complex? And how complex is the environment? So for kids who have a severe CVI, what we'll see often is they'll just stare up at the lights, and the lights are easy to see. So what we'll have to do is we'll have to turn off the overhead light and just use a light up toy to help them provide their attention to the object. So really for kids, it'd be easier to talk about this through kids who have severe CVI. So some of the adaptations for a child with severe CVI would be turn off the lights, use a light up toy, make sure the toy doesn't make noise. Thinking about it, when you're thinking about the home environment, what other sensory things are happening? Are the parents cooking? So that's a sense that the child might not be able to like ignore. So teaching the parents about that. With kids with severe CVI, we want them to be able to understand that they how to turn on their vision. And then we do that best by adapting the environment. We'll often use like a black trifold board um, to take away the background information. It just makes the toy pop out, so it's just easier to see. So the things that you're doing with a child with a severe CVI, you just want the thing that you want them to look at to be very easy to see. Sometimes you'll hear about a little room. So that's just, different people make them different ways. It could be a tent that you buy on Amazon. A lot of times TVIs or vision specialists will make it out of PVC pipe. So taking out the big room and the distractions within the room can make it easier for kids to use their vision. And they'll hang things down from like the ceiling of the little room to make it easy to see. Teaching parents that think about like their rug. So if you think about a baby and they're laying on their belly and that you want them to reach for a toy, if there's a busy oriental rug there, that's going to be hard for them to see the toy. So if that's the case, we might throw down a black sheet to make it easier for the kid to see. I'm trying to think of some other things, light board. So for a child who has a more severe CVI who might be a little bit older and they're working on school things, we use light boards. The light attracts the child's attention, but it can attract their attention to like their schoolwork or things like that.
So is your thought then that you're starting there and you're looking to eventually grade it so that
Exactly.
okay. So do you want
Yep.
to talk a little bit about that process?
Yeah. So as a child, so again, that's where we teach the parents how to read their child's visual behavior. So we, for again, the situation of a more severe CVI, we ask them to kind of pay attention to how quickly will they look at the toy and how long will they look at the toy. And as their vision gets better, they'll look at things quicker and they'll look at things longer. And so then once we're getting them to understand that they can use their vision, we'll then change the toy so that it's a little bit harder. So we might move from a single color toy to a multicolor toy or two color toy. And then we might put the lights on a little bit more so that they have to learn to deal with complexity. So it's not that you want to adapt everything. You want them to learn to deal with those harder things. But in the beginning, when a child is not using their vision very much at all, then we want to make it adaptations. We think about it kind of like in phases, or like, early stage of a development where our goal is to get them to look at something. Kids who are in like the middle stage of visual development, we want them to use their vision to make something happen. So like to reach for a toy, to activate a switch toy, to activate a cause and effect toy. And for those kids who are more mild, we're working on, the things that are still kind of in the way. So that's usually using their vision in new environments, using their vision to find things at a distance. So if you think about like a kid trying to find a tiger in the zoo, that's really hard even for sometimes us adults. You're like looking for the animal, you can't find it. And so for kids with CVI, we're trying to teach them to do those kinds of things. Or, I might have a child go grocery shopping with their parents and try to find their favorite cereal amongst a bunch of cereals. So that's a very complex environment. And so we want them to learn to deal with complexity over time.
So part of what you're doing is direct treatment. So if a kid, is from Cincinnati, and so they're fortunate enough to have access to you as a treating therapist, or other folks that are at Cincinnati Children's, what does a typical treatment session look like? What are you looking to? Is it more of a coaching model? Is it more of direct intervention, and then looking to move to more consultation after that? What does that typically look like?
Yeah, so all of the
Mhm.
above. It depends. So we start all of our episodes with the COPM, or the Canadian Occupational Performance Measure, and we ask the parents what goals do they want to work on, and that will guide our treatment session. And so I would say with every child with CVI, it's going to at least involve some kind of environmental adaptation, some kind of task adaptation, parent coaching, and parent training. We did a study here before COVID, before telehealth was cool, because I really felt strongly, as an outpatient therapist, I can't get into the child's home, but what's most important is what their home looks like. So it's hard for me to give recommendations to a parent to say like, reduce complexity. But if I'm in their home, I can say, oh, we should put up, a black border right here because this is really hard for them to look at, and this is where they're eating dinner or whatever. So we did a telehealth study finding positive results to do telehealth so that we could have access to their home environment to be able to give direct instruction as far as how, like, things that they might do to help change the environment. And then in addition to that, it was coaching. So I wanted to be able to teach the parents on how to problem solve for themselves environmental modification. So it started off with, in the beginning it was more education, and then it transitioned to more coaching to help them be able to understand how to problem solve their adaptations to the task and the environment for themselves.
And then you talked about the PowerPoint that's shared with teachers. Do you kind of interact sometimes with if they're in a preschool or a childcare or in their school that they attend?
Yeah, again, same situation. We can't get there in person, but we will talk to the therapist. We communicate with them when there's questions. I have access to a TVI in our clinic, so sometimes I might have the teacher call the teacher, like our TVI call their teacher if there's an education kind of question that might be helpful. So I know everybody doesn't have access to that, but for me that's pretty helpful. Or if there's a specific, like parents will ask me, what size font do I have to have, and what size? So I'll have the TVI. I'll bring them in for a session with the TVI, and she can do a reading assessment and kind of guide that as far as, from the academic point of view. So I will often partner with my TVI to answer some of those academic questions, but then as an OT, I can give them recommendations about the environment or some, slant board or things like that that they could use within their education setting.
And then you can share that with the school-based OT as well, probably if the child
Yep.
has access to that. How about mealtime? Does CVI kind of affect mealtime as well?
Yeah, so that's a tricky one because one of the things is in almost always behavior for a kid with CVI is they have difficulty with their lower visual field. So when you think about a plate and feeding themselves, that's in your lower visual field kind of all the time. And so that's a tricky thing. And so, yeah, so mealtime is almost always affected. And so it's something that you have to consider the vision when you're either wanting the child to feed independently. So some of the questions that we ask about mealtime when we're trying to get a better picture of it is, if they're not feeding themselves, do they see the spoon coming to them when you're feeding them? Or do you have to touch it to their lips for them to see it? Or if they're a self feeder, do they find everything on their plate? Do you use any? I always ask the parents, are they making any adaptations right now with their vision? So maybe they might be using a solid color plate versus a busy, like, cute Dora the Explorer plate. So all of those things are going to play a part into the child's independence with feeding.
Yeah, you wonder too about it. Just, finger food folks. If that's,
Yeah.
oh, kind of, I always found that, when you cut out the middleman or the middle woman, it kind of makes self-feeding a little bit easier when you've got
Yeah.
visual impairments, that's for sure.
I always ask parents too to take videos. I mean, so if I can't be in their home. So if they take videos of what it looks like, what does their setup look like? Show me a feeding session, and we'll use that in our session to be able to kind of guide the parent, or we'll just do feeding there. But again, it's different in an adapted environment. Our environments are very sterile. There's not like kids, brothers and sisters running around, the dog's not barking. So vision looks different in home environments versus in our clinic situation. So the most information I can get from parents about what it looks like for them at home, the better.
Like it seems like CVI might be underdiagnosed. I guess you wouldn't agree with me on that. So, what are you doing to help with that? Are you doing education for therapists in the area, for families? What is the Cincinnati Children's doing to help with that?
Yeah, I mean, I would say all of that. So we do a lot of education to other really OTs, any kind of therapist, but also ophthalmologists and optometrists. We present, even at our own institution, we just presented again to the ophthalmology department to kind of talk about things they should be looking for to suspect CVI for kids. We just recently got our screening tools worked into our Epic system. So now we can send the screening tools to parents so they can fill it out over my chart, so then everybody on the team would have access to that. So really trying to screen kids who we think might be at risk for CVI to understand whether or not they warrant a full comprehensive CVI clinic visit. So I think just that little step of getting that worked into Epic so that it's available for all physicians and all therapists within our whole network is helpful. Again, we have tablets, so parents will check in here, and if we think if they're scheduled for a CVI appointment, they'll get that automatically. We have a algorithm set up so that if they're here for a certain visit type for CVI, they'll get the questionnaire. There is a it has smart technology so that it answers a couple questions like about their age, about their mobility status, about you know a couple different behaviors, and then it'll assign them the correct screening questionnaire based on age and their developmental abilities. So I think just getting that worked into our medical record is helpful. We often are doing education sessions. Like we just did a 6-day presentation to a county who provides school-based services, therapists who provide school-based services. Dr. Schwartz, who's one of the ophthalmologists that I work with all the time, we're going up to Lexington or Louisville on Thursday to teach them up there about CVI, and we've done that before. So we have different I guess networks that we partner with to kind of provide updated education on CVI. But I think really the lack of awareness of um, both, I would say, medical professionals and school personnel about CVI is one of the things that's one of the biggest barriers. So the more we can get to conferences and do presentations and just talk about more about CVI, I think the better. When I did a survey last year, I think to TVIs and OTs about their educational experience with on CVI in their educational program, and it was very poor. TVIs get more training than OTs do, but I want to say it was like less than 30% of OTs got any kind of education on CVI in their school, which is sad.
Well, there's a lot of OT programs in Cincinnati, so you can help with that.
I do. I do. I actually have been to Ohio State a couple of times to talk about CVI, and I go to UC and I talk about CVI. I have groups of students who I do projects with. So I think here in Cincinnati we're doing an okay job. But the more we can get out there to teach other people, I think the lack of awareness is probably one of the biggest things that's getting into the way of underdiagnosis or late diagnosis. When kids get diagnosed at 7, 8, and 9, they've missed a lot of opportunity for really easy intervention.
Would you say, in terms of the kids that you're seeing, that there might be some issues around justice and race and socioeconomic status that kids from, um, you know, more impoverished backgrounds are less likely to be diagnosed or to be able to receive treatment?
Well, I think that where you live really does play a role. If you have a CVI program close to where you live, you're going to get probably, I don't want to say better care, but there's going to be an awareness of it. I mean, we have, like I mentioned, our CVI clinic, we get a lot of people who drive 3 and 4 and 5 hours to come and get evaluated, I think, because they can't find anybody in their area. So I think just having definitely where you live and access to care is going to play a role in the care that you have access to, for sure.
So, what are the kinds of goals that an OT might write? You've had diagnosis. We've been talking a little bit about intervention strategies. What are some maybe common goals that an OT might write and work on?
So usually, again, using the COPM, it's usually going to be related to a functional goal. So, for example, if their parent goal is feeding, then it might be to uh, provide task adaptations in order to promote self-feeding, visual adaptations, definitely the word vision. We actually are almost at the end of writing a paper. We looked at the COPM of kids who have CVI in both OT treatment and PT treatment, and we linked it to the ICF to see where are the kids' goals falling. So when we look at the kids who have CVI and they came in for treatment, the parents set their goal. Are they in activities and participation? Are they body structures and functions? Where do their goals fit? And not surprisingly, thankfully, the majority of both OT and PT goals fell within activities and participation. So um, some type of functional thing. In OT, I want to say the biggest percentage were both with reaching, so like using their motor skills for that, or feeding, self-feeding. But here in a couple weeks, hopefully we'll submit that and you'll be able to look at, huge tables of what kind of goals do parents set. But the biggest percentage of goals for OT were reaching and feeding.
So in terms of the goals, so we obviously we believe in neuroplasticity and more than believe in it. So is the goal, really to look at kind of remediation? Is the goal looking at adaptations, accommodations, and at what point do you start to make those decisions as a therapist?
So I think that with most kids with CVI, there is usually a combination of both. So for me to remediate a motor skill, I have to adapt the environment to make it easier for them to see. So I call it the double whammy. We don't want them to work really hard on motor and vision. So if we adapt the vision, they can work on motor easier. So if I want a child, again, reaching is just such an easy example. But if I want a child to reach or swat at something, if I adapt the environment, they're going to have more success because they're not working really hard to see the object they want to reach for and or move their hands, their motor skills. So I think, and then you move towards, not needing as much adaptation. So it depends on where they are on their CVI severity to understand how much adaptation. So the adaptation fades as their CVI gets better or their processing gets better. And so a good example of this is when I first started to work with kids with CVI, our lower field recommendations were all adaptations. And so, for example, when you're working on a child to walk down steps, we might put tape on the edge of the step, or when they're getting in and out of the bathtub, we might put some kind of shiny something so that they can see where the bathtub ends and where it begins, or just a mat down in the bathtub so it doesn't look all white, so they can kind of see where the water is, where am I going to put my body. But then what we realize is that we don't want to adapt all the time for these kids who are going to be mobile, or at curbs. Curbs are a good example. A lot of times we ask parents to give them a verbal warning. There's a curb coming up, you're going to have to step down. But eventually I want that child to be able to see the curb coming up and know they have to step down. So then we transitioned to starting off with adaptations, to put those visual adaptations, and then having the child find them within the community and say, either point to it, like play a game with it. When you see the curb, yell a funny word or something like that. Or when we do obstacle courses to pull their attention down to the visual field as a type of remediation. So they're kind of looking down. Or if they're playing a game, instead of having all the pieces right there or a puzzle, we put them down on the floor and have them find them first. So they have to learn to pull their attention down to the visual field versus me telling them, oh, it's down here. So I think it just depends on where they are in their phase of CVI or their ability to use their vision. We will start with mostly adaptations and then fade the adaptations and then work on remediation. But for most kids, they need visual adaptations to be able to work on something else.
So if we're going to quote that, avoid the double whammy.
Avoid the double whammy.
Yeah, you ought to get that trademarked, and you could get a little sign up and maybe stickers. You could give the kids stickers
There
and the
you go.
parent stickers and the teacher stickers when they go. So, well, it's great that folks in Cincinnati or that have access to Cincinnati Children's have access to you. What are some sources or some recommendations that you would have for occupational therapy practitioners who are interested in CVI to go ahead and learn more about it?
There are a lot of great websites. One of my favorite websites is called CVI Scotland. I think it's cviscotland.org. And on there's a lot of great videos that are just really short, like 2 or 3 minute videos about different topics that are common, or comorbidities in CVI, or different things about CVI. That's one of my favorite websites. There are different parent support groups that you can go to. There's also the Pediatric Cortical Visual Impairment Society that has some things on their website. They have a meeting every other year that there's a lot of parents there and therapists and MDs that are involved with CVI. It's usually in Nebraska. That's a great place to learn more about it. There's the American Foundation of the Blind. They have a lot of different textbooks and or different toys for kids with CVI. There's a book that a lot of parents read. It's called Little Bear Sees. It's a really easy read. So even if it was an OT you wanted to learn about the basics of CVI, that's another book that's easy to read. But yeah, there's a lot of websites, and then there's a couple books that are really helpful. Vision in the Brain is one that I reference a lot. I believe one of the authors is Gordon Dutton, the person that I mentioned with the questionnaire. So yeah, there's a lot of great resources out there.
And those of you that are listening on occupationaltherapy.com will go ahead and have a link to those resources for you. So, Karen Harpster, my former student, look at you, uh, making us all proud and doing such a great job with CVI and many other things at Cincinnati Children's Hospital in beautiful sunny Cincinnati, Ohio. So thanks very much for being with us.
No problem. Thanks for having me, Dennis.